Emphysema is the enlargement of the airways beyond terminal bronchiole or bronchi with dilatation and destruction of their wall. Types of emphysema include pan-SNR that involve non-selective destruction of all lung distal to the terminal bronchioles. They can be localized or generalized and uniform. There will be basal predominance, centri SNR or chronic bronchitis and alpha-1 antitrypsin. Pan-SNR is also known as pan-lobular. Centri SNR or lobular, it involves selective and destruction and dilatation of respiratory bronchioles. Alveolar duct, sac, alveoli are spared. Upper zone is more involved than lung bases. It occurs in smoker and in chronic bronchitis. Paraseptal, it involves the periphery of secondary lobules, lung periphery. It is combined with pan or centri SNR and it causes bullae formation. Paracicatricial, there will be distension and destruction of terminal airspace adjacent to fibrotic lesion that is seen in TB. In obstructive emphysema, distal airways are dilated but they are not destroyed. Larger bronchus, they will be obstructive. Air trap on expiration. Causes are inhaled foreign body, endobronchial, parabronchial tumor or peribronchial. Lung beyond obstruction, there will be hyperinflation. Incompensative part or all of the lung collapse, shrink or removed. The resulting space is occupied by displacement of mediastinum or diaphragm. There will be hyperinflation of unaffected remaining lung. In bullae, emphysematous space that is greater than 2 cm in distended state, wall compressed surrounding lung and the pleura. It depends upon the location. So air trapping, yes or no? In pan-SNR, air trapping will occur obstructive congenital lobar. It will not occur in centri SNR, paraseptal and compensatory. What are the radiological appearance? In pan-SNR, there will be reduction of pulmonary vasculature, periphery, hyperinflation of the lungs will occur, alteration of cardiac shadow, generalized lung will be patchy, flattening of diaphragm will be occur. In expiration, normally there will be 5 to 10 cm rise of diaphragm, but in emphysema there will be less than 3 cm. Severe diaphragm will be inverted. It occurs in barrel chest, bowing of sternum. There will be increased kyphosis, retrosternal space with increase. Heart will be elongated and narrow, and pulmonary edema will cause lung volume will decrease and diaphragm will increase. CT is the diagnostic on expiratory scan. Air trapping will occur. In centri SNR emphysema, it will occur in chronic bronchitis, uncomplicated cold minor pneumoconiosis. On X-ray, there will be in primary condition, later pan-SNR and bullous emphysema. In compensatory emphysema, radiological sign resulting from collapse or removal of all part of the lung. Bullous disease of the lung. There will locally, it will occur in normal lung. It will occur in paraseptal emphysema. Emphysema with scarring. Clinically with pan-SNR and with chronic bronchitis. Bulla is the round oval translucency. It is 1 cm. It involves the entire hemithorax. They can be single, multiple, and are peripheral. In asymptomatic or with pulmonary scarring, bulla mainly occur in apical. In COPD, it will occur in throughout lung. Wall. Its wall is smooth, curved, hairline, shadow. If wall is not visible, then there will be displacement of vessel around the radiolucent area and it will indicate bullous area. On CT scan, there will be giant wall, thin strands of lung crossing. So it's the picture of bulla, hairline structure. The black is the emphysema. Emphysema with chronic bronchitis. On chest x-ray, there will be hyperinflation of the lungs. Pulmonary arteries will be pulmonary arterial hypertension will occur. There will be increased bronchovascular marking, that known as dirty chest. So it consists of pink puffers and blue bloaters. In pink puffer, ventilate sufficient. It causes sufficient ventilation of alveoli to maintain normal blood gases. There will be no hypoxemia, and it mainly occur in panacinar emphysema. On blue bloaters, it will retain carbon dioxide due to poor alveolar ventilation. Respiratory center, there will be increased carbon dioxide. Chronic cyanosis will occur. Hypoxemia will occur, and ultimately it will lead to cold pulmonary. It occur in centri-ancinar emphysema. On X-ray, there will be increased bronchovascular marking. There will be enlarged central pulmonary arteries, cardiac enlargement, and increased marking pattern. Swyer, James, or McLeod's syndrome. Clinically, on chest X-ray, hypertransient hemithorax. It occurs in childhood due to viral viral infection, bronchiolitis, and obliteration of small airways. There will be decreased ventilation by the collateral air drift. Air trap will occur, that is known as panacinar emphysema. One lung will be affected more. Bilateral abnormalities occur in bronchiectasis, an area of hypertension. Hypertransdudency. It occurs in constructive obliterative bronchiolitis. The affected lung will be hypertransient due to decreased perfusion, smaller than normal. There will be ipsilateral pulmonary arterial visible, and they will be small. Peripheral vascular pattern will be attenuated. Air trapping will occur in the affected lung. To maintain the volume on expiration, there will be displacement of mediastinum to more normal side, restriction of ipsilateral hemidiaphragm. Radionuclide scanning will occur that will show reduced flow to affected lung. Air trapping, so that will occur in perfusion, and then the ventilation scan. So this is the chest X-ray and the CT. The DDs include proximal interruption of pulmonary arteries, hypogenetic lung syndrome, obstructive emphysema. Obstructive emphysema, it affects the entire lung lobe or segment. On chest X-ray, first the foreign causes a foreign body tumor, that is central, and a tooth. There will be vascular pattern attenuated, black, hypertransient. On fluoroscopy, on expiratory film, it will demonstrate air trapping in affected area. Deviation of mediastinum towards normal side, restriction of ipsilateral diaphragm on expiration.